Great, thanks for having me. So my name is Ed Marx. I serve as the Chief Information Officer at Cleveland Clinic. I think one of the hallmarks of the Cleveland Clinic has been innovation, and patient-generated health data and remote patient monitoring is no different. It's really a natural continuation of sort of this our tech-aware culture guided by our patient-first culture. So it's a great intersection where this sort of innovation happens. But as I share examples and I'm part of this panel, I just want to be clear, while I'm sharing some of these perspectives, I'm only representing the incredible work of many, many others, including our operational leaders, very creative and committed clinicians, and some IT wonderkins. So it has nothing to do with me, but I'm happy certainly to represent the great work that they have been doing to advance our patient-first culture. So everything we do is really centered around the patient experience. So we have this persistent focus on safety and quality. And those are the same drivers that we embrace behind any technology-enabled operations. In fact, one of our 2018 Uber objectives for our entire enterprise is called digitalization. So what we're talking about today and what we've been doing fits right in there. So very quickly, I'll give you a couple highlights of what we're doing today, and then we'll go on with the other introductions. So we took our collective experience and success with digital health and our e-hospital initiatives and transferred that same sort of entrepreneurial thinking and operational framework towards this sort of patient engagement. And so I think going from e-hospital and things that we've done there for years and years with an inpatient focus, now that digital health kind of gives us this bridge over into what we're talking about with RPM and PGHD. So we do a lot of remote patient monitoring. As many other hospitals, we take care of our sickest patients in-house. And so whenever we can allow patients to convalesce and heal in their homes, that's always best for everyone. So we're doing that today. We have many of our patients who in the past might have stayed in a hospital. We are sending them home, allowing them to, again, heal at home. And obviously there's a lot of technology involved with that, but we've seen costs go down, patient engagement go up, and quality go up. So it really makes a lot of sense for us. And then on the more active side, in terms of patient-generated health data, we have been pretty persistent in this area as well. So our numbers to date, actually at the end of 2017, just to give you some flavor for the sort of things that we do, we've had over 4.6 million, basically about 116,000 encounters per month. So totaling to about 4.6 million over the last couple of years of patients who are entering data actively. This crosses a number of our hospitals as well as ambulatory centers, 90 to be exact. We use probably 197 different formats for them to enter data. This will include everything from depression, questionnaires, to sort of data that they might collect on their own from whatever activity tracker that they use. And so we're heading towards 1 million different unique patients who are submitting, whether it's questionnaire or some sort of other patient data. So anyways, a lot of patients and well over 1,000 providers who are actively engaged in this process. So that's a bit about Cleveland Clinic, our experience with PGHD and RPM, and some quick highlights about the breadth and depth of our involvement.
Great, thank you, Ed. Next we have Jody Daniel. Jody, please tell us a little bit about yourself.
Thank you so much, and thank you for including me on the webinar. So I am a partner at the law firm of Crowell & Mooring, and I lead our digital health practice here. And really what I've been doing in this practice is helping technology companies to navigate the regulatory environment in order to help them bring their innovation into the healthcare space. And then on the flip side, helping healthcare providers figure out how to integrate new innovative tools into practice in ways that meet their legal and regulatory requirements and also their patient expectations. My one disclaimer, I am a practicing lawyer. Nothing on this webinar should be viewed as legal advice, but I'm happy to provide anybody with advice separately. But prior to coming here, I spent 15 years in the Department of Health and Human Services in various roles, and that's really where I developed my my interest in this space. I originally came on to HHS to help draft the original privacy rules, and I was focused on the patient rights section HIPAA privacy rule. So one of the things that I'm most excited about in those days was working on the patient access provisions. And then after that, I helped found the Office of the National Coordinator for Health IT, and I directed policy there for 10 years. So I was focusing on the standards and certification regulations, collaborating with CMS on the means use regulations, leading our advisory committees. But what I'm really most proud of from my time at ONC was the patient engagement work. I started our consumer health program and really flipped conversation from one that was solely focused on clinicians having data from various sources, from other clinical sources about patients, to flipping it to where the person is at the center of their care and thinking about the healthcare data and the healthcare system from a person's perspective, from a patient's perspective. I led the focus on incorporating information from patients back into the clinical setting, so focused on patient access to their own data back in the HIPAA days and the early days of ONC, but really pushed the government to focus on patient-generated health data and making sure that patients had the ability to bring information back into the clinical setting that they thought was important and relevant. And for folks who've seen the most recent paper that came out of ONC on patient-generated health data, that was a few years in the making and really started based on concerns that I had been hearing about the challenges of incorporating patient-generated health data into the healthcare setting. So this conversation today is really a huge step forward from where I've come from, and I'm really excited to be talking about how to make patient-generated health data a reality in today's healthcare setting. You know, the thing I just want to highlight is I really was passionate about this because there were a lot of clinicians in the room when we were talking about promoting health IT, and I felt like the voice of the patient was absent. And as somebody who cares for young children and aging parents, I really saw the value of having information about them and an easy way to provide information back, and really focusing on that bidirectional exchange of data. And I'm looking forward to the conversation today. Thanks.
Excellent. Thank you, Jody. And finally, we have Drew Schiller. Drew, please tell us a little bit about yourself.
Excellent. Thanks so much, and really happy to have the opportunity to be on the call. So I'm Drew Schiller. I'm the CEO of Validic, and Validic is the platform for connecting patient-generated health data from digital health apps, wearables, and in-home medical devices into the healthcare system. So our organization connects with over 400 disparate device sources, everything from FDA-listed clinical devices such as in-home monitors like blood pressure monitors, weight scales, glucose meters, et cetera, all the way through to consumer wearables and health apps on the phone. And we standardize and normalize the data from all of those disparate sources and provide one simple connection for delivery into healthcare organizations, pharmaceutical companies, as well as wellness organizations. And really, this breadth of devices allows our solution to power programs around chronic disease management, remote patient monitoring, really anything where an existing care management organization or clinician organization might want to learn more about what's going on with the patient outside the four walls. That's really the type of solution that we help power. Looking forward to the conversation today.
Great. Thank you, Drew. With that, let's jump into the discussion on today's hot topic, patient-generated health data. Ed, let's start with you again. What are the clinical and operational elements health systems need to have in place to support a scalable remote patient monitoring program?
Yeah, I think if I were to sort of create a top 10 list that I could hit on pretty quickly, there definitely has to be some thought behind the program. And the first thing for me is always alignment. So you don't want to be going out doing your own thing that's not aligned with the rest of the organization. So I always come back to the mission of the organization. For us, it's really about providing better care of the sick, investigating their problems, and further education to those that we serve. And so this actually hits on our entire mission, because some of our use cases are actually related to research and obviously caring for the sick and helping all of our caregivers. So it really has that alignment. So really the first thing, I know people might expect technical answers, but I think the top three of a sort of a top 10 list have nothing to do with technology whatsoever. The second thing being the culture of the organization. As I mentioned, we're a patient-centered, patient-first culture. So this has natural alignment. And in fact, one of our 2018 priorities, goals for our organization is around digitalization, which I think I mentioned in my introduction. So it really fits well. The third thing is leadership. right? Everything rises and falls on leadership. So you could have the best program or best alignment, but if you don't have strong leadership carrying this through from a clinician side, operational side, it's not going to happen. So those, I always tell people, first three things are all about alignment, the culture, and really leadership. Once you have those in place, the rest is fairly easy to do. So the technology, and thanks to companies like Validic and others, the technology is there to pull these sort of things off. So sometimes it comes back to logistics. So sort of my fourth thing is logistics. Do you have a way to actualize the program that makes it as easy as possible for the clinicians and more importantly, the patients? And there should be a variety of logistical options for people on how to receive the technology, whether it's they get it there at the hospital when they leave, or they're able to order it simply from your organization, what have you. The other thing is choices for a variety of connected devices. Not everyone is on a particular device or particular operating system. So whatever you do, your technology has to allow for choices. The next one is really high up there as well, and that's workflow. So oftentimes we have great technologies, we have a lot of data, but we don't ever think about the workflow of our caregivers or clinicians. And so that's really important to make sure that you have all this interoperability, which is the next thing, so that there's a natural workflow for the clinicians. Because if the workflow is broken, the clinicians will not adopt it. So that workflow has to be there, and as well for the patients. Then there's a whole team. Who's the team that's monitoring the data, that is looking at the analytics being the next one? So if there's a top 10, this is probably number 8, is the analytics. So the team going to analytics, the ability to monitor, risk stratify the population, monitor what's the escalation criteria, how do you make sure that whatever systems are set up from an analytic point of view, that we avoid provider fatigue from over alerts, those sort of things. So the last two are really about, what's happening at the state and national level in terms of laws, and which kind of leads to billing as well. So what can you bill for? It's really important to understand that. So we provide the service no matter what, but it's always good to understand what are the laws in your state, in your region, nationally, or globally in our case, and then also figuring out how does the billing work to make it easy as possible, as inexpensive as possible for everyone involved. So that's kind of my top 10 list in terms of the clinical and operational elements a health system needs to have in place to support a scalable program.
Excellent. Jody, Drew, what are your thoughts on the issue?
So this is Jody.
I think that Ed, go ahead, Jody.
Okay, so I was going to say, this is Jody. I think that was a really good summary of, I think, a lot of issues that we've heard. And one of the things that we've been working on, a lot of these, some stuff has to be customized for a particular environment. And then there are some best practices for, particularly when you're talking about complying with laws, reimbursement models, some issues to be thinking about from, some of the process and logistics and workflow standpoints that Ed mentioned. We've actually been working on an innovation playbook to help hospitals and technology companies alike to both manage some of the legal questions as well as the process questions that they're dealing with, and help folks to really think through what those issues are so that they can figure out how to incorporate patient-generated health data into the clinical practice in a way that's going to work for all parties, for the healthcare provider, for the patients, for the compliance folks, for the tech folks, and then thinking about how to customize that in a way that's going to work within the culture of the particular organization. So this is a concept that we've been thinking about and starting to work on. If folks are interested, we're still developing this, but I think every healthcare organization is facing some of those same challenges, and a process for thinking through that and thinking through those 10 issues that Ed mentioned is really helpful.
Yeah, absolutely, Jody. And I think that Ed, you hit the nail on the head when you mentioned leadership. That's one of the biggest challenges that we see of getting adoption across the board inside of a health system, is just having the right leadership bought in at the right levels to drive programs forward, rather than just having a really successful pilot that sort of dies on the vine, so to speak, because there's really nowhere for that project to go once success has been determined. So I think that's something that really needs to be nailed down up front. And then just tying back something that Jody actually mentioned in her introduction to this was the ONC pilot for PGHD that was run. One of the outputs of that was a white paper that really walks through a little bit of an implementation guide, kind of a best practices for how to think through implementing a PGHD solution inside of a health system. And Validic was fortunate to be one of the companies that facilitated that pilot, and the output of that project was really strong. And so I'd highly encourage anyone to go and download that white paper off of the ONC website that has some really good practical steps for starting to walk through some of these points that we've been talking about.
Great, and with that, let's proceed. Drew, can you provide perspective on the lesser-known technical challenges providers may experience when constructing the infrastructure to support remote patient monitoring programs?
Yeah, absolutely. There's a few things. First is one of the biggest challenges is that the data that I see from in-home medical devices and wearables is very continuous in nature. So we have, regular multiple glucose readings in a day, several blood pressure readings in a day, a daily weight reading, as well as, if you have something like continuous heart rate data, you have a true sort of continuous measure of information. Whereas if you look at the data model that clinical care teams are used to seeing, it's very episodic in nature. So it's encounter focused, patient comes in, some data is entered into the chart, and the encounter is closed. And so those two models are very difficult to reconcile. And that's one of the biggest challenges to bringing in. And one of the ways to get around that is to make sure that you're bringing in the right data at the right time and surfacing the data from almost an exception management model. So you might want to make sure that if a glucose reading falls outside of a range, or if someone doesn't record a blood pressure reading for 72 hours, those are really important pieces of information that probably need to make it in front of somebody's eyes, whether it's through some sort of an internal message system, or whether it's through an email, however your communications with your clinical team or care management team typically go. Raise up those relevant alerts so that it can be made aware for them outside of their sort of normal encounter-focused interactions. And then as a key part of that is when you do make that aware, and Ed mentioned this directly, the data have to be in the clinical workflow. So it has to be a program where a care management team or a clinician who's interfacing with a patient directly can pull up a patient's record, or even a list of patients who are in a particular remote monitoring program with PGHD in their normal workflow, and see kind of what's happening at a glance without going to a separate portal, a separate login, that kind of thing. I think that we've seen a lot of programs in the past fail because they relied on a completely separate solution or a completely separate system. And it's really critical to actually have that embedded in the workflow of the electronic health record or care management system. And finally, I think that it's really important to think through a platform approach that scales across an organization and across use cases. So we've seen a lot of point solutions where, a health system might bring in a solution for managing a diabetic population, and then they want to bring in a solution for maybe bringing in wearables for oncology, or some blood pressure management for a hypertension or cardiovascular disease population. But that solution that they already worked hard to bring in, to put in place for diabetes was really specific to that condition. And so it's important to think through, as you're starting to build out a strategy, think through how could this scale into other departments, for other patient populations, other use cases within our organization, so that we can leverage the same common interface elements, which are, bringing in data, setting the right alerts and triggers and thresholds, routing those messages appropriately, communicating with clinicians and care management team and patients. How can you leverage those common elements in one place across the organization, and then have more, disease-focused or use case-focused solutions based on the types of data that you're bringing in through those various channels. So that's really how I see the challenges and some of the solutions to those.
Great, thank you, Drew. Ed, Jody, would either of you like to add any additional comments?
Drew's comments were very in-depth, and I don't have any other thing to add from a technical perspective, but as Drew stated, and I think we're gonna find this throughout the entire panel discussion, the common threads are really gonna be all about usability, ease of use, workflow, process. And so it's very interesting to hear these different perspectives and see those common threads woven throughout.
Okay, great. Jody, what are some of the greatest misconceptions you've heard with regard to concerns about bringing in patient-generated health data?
Thank you for that question. So I started talking about patient-generated health data, I don't know, about maybe 7 years ago. And it was fairly foreign concept of, what do you mean the patient is going to be sending all this data to the doctor? I don't want all their Fitbit information. There's going to be so many volume. To hear about incorporating patient-generated health data, and I think there's misconceptions, and they are all issues that can be worked through. The three things are legal regulatory compliance, workload, and having to process volumes of data, and liability concerns. So I'm going to talk a little bit about each of those. So from a legal and regulatory compliance standpoint, there are clearly additional risks from bringing in data from a variety of sources, particularly outside of the health setting, into the healthcare setting. So it's a legitimate question that you're going to hear from your lawyers and compliance officers as you are trying to incorporate patient-generated health data into the healthcare setting. The health systems have to worry about HIPAA compliance. And it is true that if you're introducing new tools or new sources of data, that it's important to do risk assessment for that new source of data or that new tool, and develop strategies to mitigate risk. But this is, not insurmountable, and it's exactly what compliance officers do or should be doing anytime there's a new tool or medical device that's introduced, whether it's patient-generated health data or something introduced into the clinical setting directly. And that data security should be a normal part of practice for a health system that is incorporating new tools into its setting. So, there was one example of this that I worked very recently. So this is not an old example, but where a hospital's ID department was raising red flags regarding HIPAA security compliance when they were trying to get patient-generated health data regarding a patient's pain experience during the hospital visits. They were trying to give patients a device that they could just enter their pain their current pain score, so that the hospital could better develop, could better respond to the patients that were in most need of limited resources that they had, and that they can focus on those patients that were in the pain. And the hospital became unduly concerned about HIPAA compliance, and the exact same information that the patient was giving the clinician or the nurse about their pain, it was just being captured in data instead of orally. And it was a bridge too far for this organization because they were worried about the security concerns about bringing in this new source of data into their clinical setting. And instead, they continued collecting it orally and didn't get the benefit of the tool that could have helped them to better make sure that the patients that were in greatest pain were able to get the support they needed from the clinical staff. So, just an example, there are resources for health systems. This is about developing, addressing security and meeting HIPAA obligations. There are risk assessment tools that the government has come up with. ONC has security certification criteria for authentication, access control, and authorization, things like that. There are OCR guidance on encryption of data. There are tools that are available, and while HIPAA security is a legitimate concern, it is absolutely something that can be addressed and is being addressed in many health systems successfully as they're bringing in patient-generated health data into clinical care. So the second concern is workload and having lots of data to process. We heard concerns that this is going to take too much time. I'm, as a clinician, I'm going to be overwhelmed with all this data that's not relevant to the kind of data I need for to take care of my patients. And there were concerns about reimbursement for all that time, which I think we'll discuss a little bit later. So we've heard that from providers that if we're getting all this data from patients, how are we going to sift through this data? That's going to create more work. It's going to create more burden. But again, a misconception. We have state-of-the-art technology today that has dashboards or alerts or analytics that can help a clinician to make sense of the data that's coming in. In fact, can be used to reduce clinician workload by making sure that clinicians can pay attention to those patients that are in need of their services. So rather than having a patient come in every time, for a regular checkup, when that patient is managing their diabetes well, they can use that same time and focus on patients that really their diabetes is out of control or where they need additional support, and they may be able to see that patient more often and have more touches with the patient who's in greatest need. Honestly, I think in this case, there is a role for better evidence and studies to demonstrate improved outcomes and cost savings that can be associated with good remote patient monitoring tools and patient-generated data. And for folks who are interested in that, the AMA actually summarized some of the current evidence in its comments to the CMS physician fee schedule rule. But I think it's an area where more study could help to address some of the concerns of clinicians that have not yet adopted the use of patient-generated health data. There are concerns about the data from patients not being accurate, but again, I think this is a misconception. Providers are often dealing with inaccurate data. EHR data is not always accurate. It's not always complete. Sometimes it's out of date. We know that clinicians rely on self-reported data in making diagnosis and decisions all the time. Patient comes in and that's basically, a lot of the information they're getting about the patient is what the patient is self-reporting. So if we're able to bring in better biometric data, or even if we can rely on self-reported data regarding symptoms that are captured in real time, rather than based on a patient's recollection over the course of days or months, again, it could be an improvement on the data and the information that they have in making those diagnosis and treatment decisions today. And then the third piece was about liability. And again, I think it's a legitimate question to ask. The clinicians are concerned about the risk of having volumes of data and not acting on data and missing some key indicator that would have triggered them to pay attention to a particular patient or to notice that there might be something particularly of concern with a particular patient. But again, I don't think it's so different from what they have now. Providers get lab test results, asynchronously from the time that they order them and they see the patient, and have to have processes in place for processing that information and figuring out which lab results are not within the normal range and following up with patients. Providers have had to routinely figure out how to address concerns of patients after hours and develop best practices for how to do that. Even though they might not have all their EHR data in front of them, they might not take notes directly in their EHR. The patient might be in an emergency situation and it might take 20 minutes for the provider to get back to them, and there are processes in place for alert the patient that they should be calling 911 if it's an emergency. So, again, on this one, it's similar to issues we've dealt with in the past, and I think that what is necessary is just to establish good processes and protocols for how to address that risk. What's happening now in the absence of protocols are that providers are doing it in scrappy ways. They're using secure text or email to respond to their patients rather than well thought out workflows and secure channels. So that not figuring out how to do this the right way actually increases liability as well. So what I usually recommend to healthcare providers and health systems that are thinking about patient-generated health data is to make sure to establish good practices up front, have strong communication with patients in advance about expectations about what the responsibilities are of the clinician and of the patient sharing this data, And then developing, as Ed was saying, good dashboards or alerts or workflows to make sure to triage information and understand when there might be an issue that a clinician should respond to. And then as the lawyer, I have to say, it's always good to have good disclaimers and reminders about what the clinician will and will not do with the information that they receive.
Excellent. Thank you, Jody. Drew, Ed, do you have any comments you'd like to add?
I think that was very comprehensive by Jody. I think
very thorough.
A couple others that we have had to deal with in the past, or I've heard from others, is about the cost. But actually, the cost, I think the models have proven that it's much less expensive for both the patient and the provider when you have these sort of processes in place. And then in terms of interoperability, that's another sort of pushback I've heard in the industry. But as we've been speaking about with companies like Validic and others, we have experience with a lot of different organizations who have APIs or these sort of interfaces that are pre-built that allow a lot of simplification into very common EHR platforms that the majority of providers run. So I really think that maybe that was an issue 5 years ago, but I don't think that's an issue no longer, and the same with costs.
Great, thank you. Ed, how do you merge the episodic care model of the in-hospital environment with the continuous care model needed to support remote patient monitoring?
Yeah, well, as I mentioned earlier, we're very fortunate to have a lot of experience to draw from with our e-hospital experience and a lot of digital health, virtual care experience that we've been doing for a while. So the transition hasn't been, like a giant leap for us. It's more like a natural progression. But I would think for many people, maybe the best way to think of this is in a transition of care environment, a good way to get started. So you can select specific cases or populations to work with. For instance, bone marrow transplant patients, you might provision them with devices prior to them leaving the hospital. And then on the outpatient side, the nursing team monitors the data flow. So there's this handoff. So transitions of care are always very tricky in organizations, but this would make for a very natural handoff. And this is just one use case. I'm certain that our listeners have many others in their particular organization, but I just categorize it as a very natural process that all of us are familiar with, and that's transitions of care. So you just got to make sure that the handoffs are there, and see, it goes back to workflow again. It goes back to usability and very little with technology. But as you can see, there's logistics involved and analytics that we've spoken about. And the other way, another method, if you will, to handle it is using analytics again and really doing segmentation of your population. And those patients who have poorly controlled diseases or newly discovered diseases, you can recruit into your connected device home monitoring care programs that we've been talking about, and it would be very natural to do that. And then as you gain experience, obviously you can replicate the model. We're always about whatever model we set up, we want to make it replicable so that we can add it to other use cases and not reinvent the wheel, and same with the technology that we deploy. So those are a couple of different ideas. And I think finally, from an industry perspective, we need to push our core EHR vendors into developing specific modules for this sort of care, because as we all know, and why we're having this discussion is the future is not about brick and mortar. It's really about treating the patients in the best environment for them and at the highest levels of quality and the lowest cost. And so we really need to continue to push our industry to develop more natural functionality within their software that can enable these sort of transitions that we're talking about.
Excellent. Drew, Jody, do either of you have any thoughts you'd like to add?
Yeah, Ed, I think those were excellent points, and you're dead on about Cleveland Clinic having such an amazing view from your past experiences in this space. One thing I will add to that is that and it's not specific to the continuous care versus episodic care model, but one thing that's really important is having some way for the care teams to provide device management for patients. So, whether it's provisioning of the devices to the patients, giving the patients a simple workflow for authorizing their data to flow in, and then once the patients are enrolled in a program and they're bringing their readings in on a regular basis, it's important for the care management team to have the ability to support the patients as they use those devices to help troubleshoot or determine if there's anything going wrong. So that's a really important piece of this as well that I think is an adjacent component of what you just were talking about.
Excellent, thank you. This next question is for Drew. Are data standards still a market challenge with regard to PGHD and integrating these data points in the clinical environment?
Yeah. I mean, it's healthcare, so I think data standards are always going to be a little bit of a challenge. I will say though that they are improving dramatically for patient-generated health data, and so I'll talk about the two sides of that. One is accessing the data from devices, and one is actually bringing the data into the clinical workflow. So on the getting the data from the devices, there are standards such as Bluetooth LE that are in place to communicate with data from weight scales, blood pressure monitors, even wearable trackers. And those standards have been in place. They're well known. The challenge is that a lot of for security reasons and other purposes, there are a lot of device manufacturers who choose to generally implement their own flavor of Bluetooth. So you couldn't just use the standard Bluetooth protocols to get the data from the device. You generally speaking would have to work directly with the manufacturer, or sometimes the manufacturer prefers to own the device to mobile phone or the device to cloud connection on their own. And then that way the data are accessible via an API. And so you can get the data from the cloud. And in that experience, you have a challenge where there are no standards for how APIs should structure information such as this in the cloud. So there are standard protocols for accessing data via an API, but in terms of the data models themselves, they're fairly disparate. And so one of the things that I do to help with this is that I'm on the Health and Fitness Technology Division board for the Consumer Technology Association, which is the industry group that puts on CES every year in Las Vegas, the world's largest consumer electronics show. And this division has representatives from the largest health tech companies in the world. And we also have a corresponding standards body as part of this Health and Fitness Technology Board. And we actually have 3 live working groups right now that are setting standards. One is around physical activity monitoring. So we actually set the first standard around step data, and right now the group is finalizing a standard around heart rate data. There's another working group that's working on standards for sleep, for displaying and accurately acquiring sleep data, and there's another one that's working on EEG. So this is a really important industry-led standards group that's putting out ANSI standards around how to actually validate that the data are accurate, and also determine how best to deliver this information. And then in terms of bringing the data into the clinical workflow, it's actually getting much better because of FHIR. And there's been there was quite some time where FHIR was talked about frequently but not often implemented, and now we're finally getting over that hurdle where now it's a part of EHR implementations really across the board now, and it's really encouraging. And specifically for patient-generated health data, the FHIR services that enable observation rights are critically important, and we're actually starting to see that from the major EHR vendors, that is now something that's coming out, which makes the interchange of patient-generated health data into the EHR a lot easier. And as far as the clinical workflows are concerned, the implementation of SMART the Smart App platform really enables the display of dashboards and applications inside of that clinical workflow with very limited efforts by either party, by either the health system or the app developer themselves. So it's a really strong, good way to integrate data into the workflow so that care management teams, clinicians, et cetera, can actually use the information in the way that they would expect to use it.
Great, thank you. Jody, Ed, do you have any thoughts on the issue you'd like to add?
Yeah, this is Jody. I thought that was great. I just wanted to add one thing from the vantage point where I used to sit, which was back in ONC. When we first set the criteria, the certification criteria for electronic health records for patient-generated health data, there were no standards that were included in that criteria. The criteria is called Patient Health Information Capture, and it requires that an EHR be able to have a user identify, record, and access information directly and electronically shared by patient, as well as reference and link patient information documents. Like I said, there was not a specific standard that was identified, and ONC intentionally kept the definition broad and didn't define the types of health information that could be accepted or the standard for sharing that information. The goal was really to not impede innovation and to allow these tools to develop, and there wasn't sort of one way of doing it at the time when we put this out. As Drew had mentioned, we do have some clients who are successfully using FHIR resources to transmit question and response data to the EHR, and we're seeing folks increasingly using that standard as a way of incorporating some of this data, but at least from a regulatory standpoint, there is flexibility on how it is done.
Yeah, I was happy to see a lot of recent emphasis at the federal level now looking back at standards, since there's been a lot of maturity in the last few years from a technology point of view. And I think that the vendor community had been a little bit resistant to actively engage or I shouldn't say actively engage, but proactively develop standards that everyone could agree on and get to the level that we need to for the benefit of our patients and our country in terms of healthcare and its impact on GDP. And so I'm glad to see we have some of our team is actively engaged in Washington and helping to craft future standards that will be adopted, because that is perhaps from a tech point of view, the single biggest barrier that we run into in terms of trying to accomplish all the things that we're talking about today and really improve the quality of healthcare in people's lives.
Great, thank you so much. This will be our last question as part of the presentation. After this, we will move into our audience question and answer portion. Jody, what new CPT codes or code changes can we expect to see over the next few years to support PGHD usage?
Thank you for that question. I think the most amazing development in this space was in the recent physician fee schedule rule, where CMS took what was to many a bold action in unbundling the 99091 code, which is a remote monitoring code, and allowing separate reimbursement. It was really a big step in promoting reimbursement for remote patient monitoring. And we're seeing many companies, many tech companies and healthcare providers that are looking at this code as a way of getting reimbursed for using new innovative tools with their patients. I'll say that the lack of, or the concerns about reimbursement was one of the loudest concerns that I had heard over the years about incorporating patient-generated health data. So I think this is a really important step in the right direction. That said, the 99091 code is decades old. It's a very old code from before we had any remote monitoring tools, before we had any smartphones, and before a lot of folks were even using computers. So while it's a great step forward, there are some significant limitations that this code has. One, it focuses on biometric data points such as blood pressure, and we know that patient-generated health data technologies can provide rich data sources that go beyond that, including patient-reported information about symptoms, nutrition, fitness, and other kinds of social determinants of health. So the biometric data only gives one slice of picture from a patient perspective. The second challenge is that it's a one-way flow of information from the patient to the provider. It's not a bidirectional flow. The third and final limitation is that this really was a fee-for-service code, so it only pays for the amount of active time that a clinician is looking at the information. Now, it doesn't have to be a doctor, but if in fact the tools help improve efficiency so that a provider can scan a dashboard and realize that a particular patient doesn't need their time and attention, they might not hit the amount of active time with that patient to be able to bill for that code. So as tools help providers become more efficient in monitoring their patients based on patient-generated health data, this code may not work quite well. The other thing CMS has done is they've adopted other codes that reflect the changing nature of the healthcare industry that would not be in a traditional fee-for-service system. So specifically, they have codes for chronic care management, for behavioral health integration, and for transitional care management. And these codes really allow for monitoring and coordination of care for certain patients, not all patients, and allow physicians to be reimbursed for some of the services that don't occur in that face-to-face engagement. So again, CMS is showing that they're trying to better support the incorporation of time and effort that goes into monitoring coordination of care for some types of patients. Going forward, we know that CMS looks to the American Medical Association with respect to CPT codes, and the AMA has taken up the initiative and set up the Digital Medicine Payment Advisory Group, which is developing new codes that could cover a broader array of data types and use cases related to remote patient monitoring. This work is ongoing. We expect CMS to be tracking the work that this DEMTAG, as they call it, is engaged in. And our hope is that there will be additional codes that support patient-generated health data and remote patient monitoring in the future, and that this is a trend that CMS will continue to engage in as they think about reimbursement for some of these services. Often the way things go is as CMS, as Medicare begins paying for things, often private payers will also increasingly cover certain kinds of codes as well. So the expectation is that we would not only see this in the public payer market, in the Medicare market, but also in the private payer market.
This is Ed. I think that's great what Jody was sharing, and very important. The other common theme that I'm picking up, and it's related to some of what Jody was sharing, and that is that we have to be engaged. So, you know, one of our leaders in digital health is engaged on that committee with the AMA to try to, push for the new code adoption. And as I mentioned, we have someone else really advocating hard in terms of the standards, having data standards for interoperability and those sort of things. And we have to do it on behalf of our patients. So if no one, who's going to advocate if not us as leaders in healthcare, those on the panel, those listening, all of us have to get engaged at whatever level we can and advocate on behalf of our patients. Because again, if we don't, then nobody will. So we should continue to push our professional organizations that we've talked about, continue to push the federal government on both the state government level and federal level, so that we can see the true promise of healthcare and technology as the two merge together and really improve the lives of not just people here in our country, but around the world.
Great,
well
thank you
said,
both.
Ed. Yeah.
Drew, do you have anything to add as well?
No, I'm good. I just appreciated Ed's perspective there.
Excellent. Well, thank you to all three of you for that lively discussion. Three of you shared a lot of great insights. We are now going to move on to our audience-submitted question and answer session. This is your time to ask the panelists any burning questions you have in mind. As a reminder, you can submit these questions in the Q&A box at the right of the presentation window. You have already received a lot of insightful questions, and we'll try to get to as many as possible during the rest of the session. This first question is for Drew. How do you ensure that connected healthcare devices are secure?
Yeah, so this, full disclaimer, this question could be a whole can of worms and probably its own webinar. So I'll just kind of hit a few high points, because the directions you could take the security of devices could be varied. I'll start with, back in early January, we all started the new year with the news of the meltdown and Spectre vulnerabilities with the chipsets that are so common in many of our devices. And I want to start by saying that those vulnerabilities actually don't reach the level of a lot of the medical devices that we have, the connected medical devices that we have in the home, just because those are much lower level chipsets, and don't typically employ a lot of the more higher powered chip features that were vulnerable from the meltdown inspectors. So at sort of a basal level, there is a benefit to the simplicity of the relatively low frequency data communication required by these medical devices. I will say that there's been a number of papers and research studies out there about Bluetooth hijacking and things about how you could sort of sniff a packet out in transit and potentially follow that through an ecosystem to kind of get access to some data potentially in the cloud. But I'll say that that's by and large fairly benign today. And the reason I say it is because many of these devices, as they go from device to app to cloud, implement just very standard, strong, secure web service protocols. And these security protocols really limit the reach of any sort of hacking or sniffing attempt. And so it's really important to understand too is that while there could be some activity going, it's fairly low value for what data you'd actually be able to get access to through that. And then finally, I'll say that I'm aware of some emerging industry groups and standards that are coming together to solve this broader challenge, not because it's necessarily an imminent present concern today, but because as we look into the future where millions and millions of patients are using devices in the home to monitor conditions, as Ed was saying at the beginning, as we really start to see the home as a center for healthcare, there is a need for things like very clear data security and encryption at the chip level on the medical device, through the app, through the cloud, into the electronic health record, with very secure, strong encryption and also identity management throughout. So there's several projects being worked on right now at the industry level that I think are going to start to gain traction here over the next 12 to 18 months that will really start to address this. It's something that for obvious good reasons the device manufacturers are very concerned about and are thinking through in very smart ways.
Great, thank you. This next question is for Ed. Once data is received by the healthcare provider remotely from the patient, is the healthcare provider then responsible for that information?
Yeah, I think it depends on the exact type of data that we're talking about, because as we mentioned, there's a lot of different types, but certainly if it's one of our official sort of questionnaires or things of that nature, we would definitely take responsibility for that. If someone is uploading, and I'm making up this example, if someone is uploading a lot of Fitbit data and has an expectation that the physician is looking at their data on a daily basis, almost acting as a coach, that's probably something they need to discuss directly with that physician. So some things might not fit precisely, but that's a dialogue between the patient and the physician. But there's a lot of things that we definitely own because they're part of a process that we've established with our patients. So again, I would push it back to direct communication between a patient and physician as to what the expectations are.
And if I could just add one quick comment on that, from a compliance from a HIPAA compliance standpoint, if it is identifiable patient health information, then the entity, the healthcare organization, should make sure to protect that information if it retains it in accordance with rules.
Great, thank you both. This next question is for Jody. Communication with and from patients regarding the PGHD is often done by encrypted email and unencrypted text message in violation of OCR requirement of duty to warn, which is so easy to perform and document. Could you please discuss that further?
Sure. So a few years back, there were a lot of questions about improving patient access to their information. It was in that context, but it applies in this context as well. And that most patients are not likely to go to a secure portal in order to download their information and want their doctor to just be able to send it to them in their regular email account. So what HHS stated was that if a patient should be able to make their own choices about how they will receive their information, and if a patient wants to receive their information in an unsecure email or through unsecure text, they should be allowed to do that. But the healthcare provider has basically a duty to warn them that that might not be secure, and that there may be some risk in information going out. So what this means is that the healthcare provider that wants to text with their patient using unsecured text, for example, needs to let the patient know that this might not be secure, and there's some risk of your information getting out, and would you like to continue using text, understanding that security risk? And if they say yes, they would like to receive information from their clinician through unsecure text or unsecure email after a light warning, that the healthcare provider is not in violation of the rules for complying with the request of the patient to have that information sent to them through the means. What I usually advise healthcare clients to do is to document that. So if they get that they've provided that warning and that the patient has agreed to that, understanding the risks, to make sure to document that. But then again, it's about trying to provide patient access to their own information and availability of information from the patient to the clinician in the way that makes the most sense for the patient. And the rules are not trying to get in the way of provider-patient communication.
Thank you. And with that, we'd like to thank you for attending this webinar and submitting your questions. I'd like to thank our speakers for participating in today's webinar and for sharing their thoughts on patient-generated health data. As a reminder, we will be sending you a copy of the presentation to the email you used to register in about a week following this webinar. Thank you again for joining, and we look forward to seeing you at future events.